Yes, that's an extremely important question. I think one that is yet unsolved. I think there's various attempts of explaining that. First of all, the difference towards vitamin K antagonists. One of them is that we act downstream of factor 7A. So factor 7A, as you know, is the direct binding partner for tissue factor. As we can see here in the slide, there's abundance of tissue factor in the brain. We do not inhibit this factor with our novel anticoagulants because they act downstream, whereas vitamin K antagonists do inhibit this very important pairing factor of tissue factor in the brain. So this may be one of the sort of mechanistical approaches to that, and this is certainly true for both cases. The other one, and that I personally prefer, as a matter of fact, is the idea of plasma levels. As you know, with vitamin K antagonists, we have a very strong and very constant inhibition of coagulation, as can be seen in the INRs. Now, those may fluctuate, but as soon as we're over 2, 2.5, and so on, we have a substantial inhibition of coagulation. And this is obviously not the case with these new substances. They have a plasma levels that go up after 1, 2 hours, 1, 2, 3 hours, they reach their max, and after that they come down again. So if you happen to have just a small minor bleeding, this may just not play a role almost over 50, 60% of the time after taking a single dose of a NOAC. In contrast, because with your plasma levels, you're just down towards the trough level. Whereas in vitamin K antagonists, you're constantly up there with your levels, so even minor bleedings can turn into catastrophic events such as intracranial bleeding. Now, why is this not the case anymore once you combine them with antiplatelets? It may in fact just be the antiplatelets that do that. Because as we know and as we come to learn, and this is one of the reasons why aspirin's importance has dropped so much in atrial fibrillation, the rate of severe and in particular intracranial bleeding with aspirin and vitamin K antagonists is not all that different. Aspirin is actually quite a dangerous drug. And this is why there's actually, in terms of bleeding difference, there's not much of a difference in terms of the recommendation of the ESC. If we're talking about trying to prevent bleeding, switching from a vitamin K antagonist to aspirin is not an option because your bleeding complications, especially the severe bleeding complications, are going to be similar. And this is probably why this is attenuated once we pair them with a platelet agent.
Thank you for the nice explanation. Other questions from the audience, please? Stefan.
Maybe I follow up with, excuse me, one question. We have now 3 agents. 2 are direct factor 10 inhibitors, 1 and thrombin inhibitor. From a pathophysiological point of view, do you think there are important differences which we should take in consideration, or are they pretty much the same?
Well, in terms of mechanisms, there's obviously, as you know, there's been a lot of speculation which may be the best. There have been ones, promoting factor 10A because it is further upstream and hence, catches the horse before it has bolted the barn, sort of. On the other hand, thrombin, the most important player in this auto-feedback loop that has the 1,000-fold attenuation of the coagulation cascade. To be honest with you, initially I personally thought that the direct thrombin inhibition would probably turn out best. However, I think it is always a combination of dose, way of administration, and the coagulation factor that they work on, the combination of which then in fact turn out or pan out in the clinical trial results. And so I think, on top of all theory, what may be better, what may not, turns out they're both quite good, and both mechanisms, depending on the dose and the drug, seem to work.
Other questions? There is one. Do we have a microphone?
And kidney failure as well. And in that case, maybe the bigger trunk has a little bit of an advantage?
Thank you for the question. Maybe I repeat it for the audience. The question is drug-drug interaction. What is to be watched for? What is the preference? And maybe very practical addition. How do you handle the combination with amiodarone and dronedarone?
I think that's a very important question, and I think, and you're absolutely right, I totally agree, these are certainly the ones, the elderly patients, patients with renal insufficiency, that deserve very special attention. And this is why, unfortunately, obviously we could spend the entire afternoon talking about these subgroups, these special situations. in this setting, I only wanted to give a brief overview, and I think it wouldn't do the scope of the problem justice if I try to answer that in a half a minute. I think this is something that we will dig into later on and dig into deeper. It's absolutely, but you mentioned a very valid point, yes.
I have one question as it relates to the heart valves. If we look at the entire data set in patients with atrial fibrillation, we have more than 50,000 patients, and the data are consistent that they reduce the risk of a stroke. There is even indication that they reduce mortality, so they seem to be more effective. Yet, in the setting of prosthetic heart valves, they fail. Do you have any mechanistic explanation?
Well, I think we have to be careful. I think they failed in one trial. I think this is a very good point. This is a very valid point. I think they failed in one phase 2 study, and chances are that it will take a long time, if ever, that they will be studied again in this indication. But as you know, it's always a matter. It's always a question: what type of patients are you looking at? Are you trying to use these agents in patients that have just been operated on? So in a setting where thrombogenicity is very high, and this was one of the arms that they actually tried in the REALIGN study, or are you trying this in patients that are on long-term anticoagulation that have been implanted years before, where we have a very stable situation? This may be completely different, in my view. The only problem is that we're so vigilant with respect to these drugs and also in these trials, obviously, that once we see a signal that may imply harm, these studies need to be terminated, and that's what happened with the REALIGN study. So I think this setting, acute application of these drugs in the setting directly after operation, in the dose that they tried, which was comparatively high compared to the standard treatment, that failed. However, in my view, that does not necessarily mean that they are useless in this indication after all.
David?
That was a great talk. Can you tell us a little bit about what is the penetration of the use of these drugs throughout Europe? You would make the case that it should be 100%. It's probably not 100%. In the United States, it's much less than 100%. Can you talk a little bit about the practicality of guidelines and application of guidelines?
Absolutely, that's a very good point indeed. What I can certainly tell you is that it is extremely heterogeneous all throughout Europe, the penetration. As a matter of fact, in Germany, penetration has been similar to the US. So after the third, fourth, fifth quartile, also the bigatran was out earlier than rivaroxaban, as in the States, in Europe. There was a pickup of about 20-25%, which is not bad, but it's certainly not 100%. And I personally think 100% is certainly also not the goal, because as you know, there's certainly a lot of patients that do not qualify for these drugs. And we've seen, in particular in New Zealand, what happens if we have a very large pickup of these drugs. We run into troubles, and even patients that should not be treated with these drugs will receive them. In Switzerland, the pickup was a little bit lower. To be honest with you, I cannot give you the exact number. Maybe Jörg has an exact figure for that, or Stefan?
Well, I think David's question is the perfect bridge to the next presentation, and I would thank Jan Steffel for his presentation and have the pleasure to introduce my co-chair, Jörg.